Started. Okay. Let me get myself ready. Good afternoon. Good afternoon, all, and thank you so much for coming to the Health and Wellbeing Board meeting today on the 21st of September 2021 at 3 o'clock. Can I inform everyone that of notice of recording, that the meeting will be recorded for subsequent use, whether it be on YouTube or in other places. So please be careful what you say. Also, people will be allowed to take photographs at the meeting, and those could be used. So can I ask those that wish to speak to indicate using the chat function or by that raised hand function when they want to speak? And please don't come in until I call you in, because it just means we have more order. Can I ask you all to please switch off your mic and your video when you're not speaking? Can I move to the second item, which is the apologies? Today we've had apologies from Deborah Cadman, Andy Coldrick, who isn't very well, and I'd like to say I hope he gets well soon, from Kevin Crompton, from Graham Betts, but Louise Collette should be substituting for him today, from Professor Robin Miller, from Dr. Justin Varney, but Mary will be here today substituting. Then we've got Waeed Salim, who's also sent his apologies, and Douglas Simkis, who has also sent his apologies. But can I say that Andy Cave, who's with us at the moment, unfortunately will have to leave the meeting early because Andy has another pressing engagement that he needs to be at. So Andy, when you need to sign off, by all means, just log off, and thank you for at least trying to get here this afternoon. Now, my next item is declarations of interest. Can I say, if any members of this board, can they be reminded that they must declare all relevant pecuniary and non-pecuniary interests arising from any business to be discussed at this meeting? And if a disclosure of pecuniary interest is declared, a member must not speak or take part in that agenda item. Any declarations will be recorded in the minutes of the meeting. Thank you. Now, this bit, I've asked staff to ask Graham, over to you before I move to my next item.
Thank you. Good afternoon.
You're not supposed to be here, Professor Betts.
But Louise is on holiday, so I'm
oh well.
I had to shuffle our diaries about to make sure that we were properly represented at the Health and Wellbeing Board, so I will be here. Unfortunately, as you know, I'm covering for Deborah, so I will need to leave a bit early, I'm afraid, if that's okay.
Well, if you have to leave early, just can I ask you to just put into the chat box when you're leaving, and thank you for coming along. I didn't expect you anyway. I was told you weren't going to be here. So thank you for coming. Now, my next item is Paul Jennings. Paul, can you put your camera on, please?
If you can bear it, Chair.
I can. Maria, can you switch your camera off?
Yes.
Right. The member.
Sorry.
That's all right, Maria. To all the members of the Health and Wellbeing Board, can I just say that I have known Paul, I was trying to figure it out, for probably nearly 30 years. As you know, I'm only 21 and a half, but I've known Paul since before I was born. So it's one of those ones. And I have to say that Paul has been one of the nicest people I have ever met throughout my career and in everything that I've done. He's always been there for me personally. Sometimes I don't see Paul for probably 5-6 years. And when I see Paul, it's as if we'd spoken yesterday. He's always been there to give advice. He's been a brilliant member of the Health and Wellbeing Board. He's always been there to support and steady this system. And in the last 3 years, has it been, Paul? Since you've been back in the, oh my gosh, and in the last 4 years, I don't know what the Birmingham and Solihull system would have done without him, because he's come into the system, he's brought his brilliant personality with him, he's been able to steady a lot of he's calmed a lot of the waters, he's been a brilliant leader. But he's retiring and he's leaving us. So as the Health and Wellbeing Board Chair, Paul, I just want to formally say thank you for everything you've done, not just in your time as the CCG Chief Exec or the STP Chief Exec, but for all the work you've done in the NHS over about 40 years. It has been an absolute pleasure to have worked with you, and I am going to miss you. I'm personally going to miss you because you've always been there to just give that encouraging word. So, Paul, I know as a system, we're going to miss you, but the Health and Wellbeing Board is truly going to miss you because you have never said you will do something and it's not been done. You have never said you will deliver on something and not delivered it. You don't just talk the talk, you walk the walk. So I'd just like to say thank you so much. I wish you all the best on behalf of myself and every single member of this board, all the best for the future. I know you're not going to go around in that van for very long. I also know fishing or whatever else you've got planned is not going to be enough, but I hope you enjoy whatever you decide to do when you start your retirement. All the best, and thank you very much for everything you've done for this system.
Paulette, thank you so much. That was so generous and kind. I've loved every minute of being back here in Birmingham, and although not as Chief Executive of the CCG, I'll always be here for Birmingham, and I'll certainly always be here for you. Thank you.
Oh, bless you. Thanks a lot, Paul. Right, now we move swiftly on. Right, the dates of the meeting. To note that this municipal year, we've got a meeting coming up on Tuesday, the 30th of November, but that meeting will be face-to-face. And we've also got another meeting on the 18th of January and on the 22nd of March of next year. We may have to squeeze another meeting in there, but at the moment, these are the published meetings, and the board will continue to meet between 3 and 5 o'clock. Now, can we discuss the notes from the informal meeting, which was held on the 27th of July? I am going to presume that everybody has had the opportunity to read those notes. Has anybody got any actions or anything in the notes that they would like changing? If so, sorry, I'm looking at what Stacey has just written and it's taken me off track. And if so, could I could you put your hand up so I can hear? Otherwise, I will sign them off as an accurate reflection of the notes from the informal meeting on the 27th of July, and we will move swiftly on. Stacey, can I go straight over to you? Item 7. Have we got anything on the action log that you want to highlight?
Thank you, Councillor Hamilton. There aren't any outstanding actions on the action log at the moment.
Thank you, Stacey. Now, the next item is the chair's update. Now, I've just done a big bit of my my update, but let me move swiftly on to the chair's update. Right, I hope everyone has managed to get back from their leave and they've managed to get a break over the summer. I have to be honest, for the first time in 2 years, I've managed to get away myself, and it was absolutely fantastic. I do hope everybody has managed to recharge their batteries and that you're ready for the challenge with the upcoming winter pressures. Can I start by saying, on Friday last week, I sent a letter to the Right Honourable Sajid Javid MP in his new role as the Secretary of State for Health and Social Care. And in that letter, what I was doing was outlining our concerns in Birmingham with the need for all of our care staff in our care homes to be double vaccinated by the 11th of November. Now, this wasn't just a single person working together. Adult social care were brilliant. They ensured we got the information we needed so we could put together an accurate and a thoughtful letter. But as you're all aware, we have been clear on our messaging and promoting the vaccinations. And as you know, I have felt that it was crucial that people had their vaccinations to ensure that they could prevent the disease, or at least if they did get the virus, it would not be as bad. And I am absolutely supportive that all care and frontline staff should be vaccinated to help protect themselves and those that they care for in the wider community. We've also been working very closely with all Birmingham care homes throughout the pandemic and supporting them as best as we can through this very challenging times and the challenges that we face. Our health colleagues with us have been leading on vaccines. They've done a phenomenal job, and they've also been busy with the COVID-19 rollout flu booster. And I can say to you, on Saturday, I received my booster, and I've never seen an operation like it. It was military. Also, our health colleagues have absolutely been brilliant in their efforts in rolling out and promoting the vaccine take-up and responding to concerns with COVID-19 vaccinations. However, more time is needed to ensure we have sufficient care staff vaccinated to avoid an impact on essential care and support. Our current local data shows that up to 2,690 workers could be prevented from working in care homes on the 11th of November unless they become fully vaccinated. And although I recognise that recent announcements regarding self-certified temporary medical exemptions, which will be inevitable, will assist in the short term, it does not lead, it won't be enough. And it also means that yet again, we've got these conflicting messages. So what I did, I worked with staff to just make sure we got the right asks, because this isn't about blaming. This is about ensuring that going forward, we were on the same page. And what I've done is I've asked the minister to delay the implementation of the rules for the care home until March 2022. And this was to avoid the winter period, so it can be coordinated with a future approach to the wider health and social care workforce. Also, proposing in the interim that we reduce it from 100% to 80% of care staff within any given care setting to be fully vaccinated. Not sure if we'll get it, but we have asked. As without this intervention, 16% of the care homes are expecting either significant disruption and will not be able to keep the services safe based on anticipated staffing levels, and as winter pressures emerge along with the anticipated bad flu season, we are expecting we could be in a situation of mass unavailability of care home beds. Once if I receive a response from the minister, I will ensure I share it with you all, because this is just such a serious issue. Now, I'm not sure, but Councillor Sharon Thompson has just taken over from Kate Booth. I'm not sure if she's in the meeting, but if she is in the meeting, I'd like to welcome her. She has got a tough act to follow from Kate Booth, but I'm sure she will fill those boots willingly. And on that note, I don't want to speak anymore. I've talked enough today, so we will move on to the next item. Right, now the next item is around public questions. Now, we have received a public question this month, which has been detailed in the report. So when you read the report, it is the response is item 4.3 in the report. So I'm asking members of the Health and Wellbeing Board and anybody else who's interested, there is a public question that was submitted, but it needed a lot of detail for it to be responded to. So we've decided, because the person who posed the question isn't going to be at the meeting, what we would do is we would put it in the notes, but we won't discuss it in the meeting. So can I ask members of the board if they've seen it? Recommendation 3.1, is that agreed? Read the public question. I feel as if I'm talking to myself, but I know I'm not.
Agreed.
Agreed. Okay. Brilliant. Brilliant. We will get into the swing of this. We've just had the summer off. Right. Now you will stop hearing from me. The next item is the coronavirus 19 position statement, which Dr. Mary Otheo, I always say your name incorrectly, the Assistant Director for Environmental Public Health, will present this item. Mary, over to you. Thank you.
Thank you, Councillor Hamilton.
My pleasure.
So I'm just going to go through the highlights, as you will all have received the paper. I'm about 18 months into this pandemic now, and the situation in Birmingham is that our case rate is falling. So in the data for sort of data up to the 6th of September was just over 2,800 cases, with 2 new deaths in the 60-day trend being shown. What this is saying to us essentially is that we're still getting a lot of infection, but fortunately, although that is translating to pressure on the health service and the health system, it's not translating to deaths in the way that it did perhaps a year ago. So total number of cases obviously is up, but the rate at which we're getting those cases is falling and has fallen and continued to fall. We do keep an eye on the proportion of those cases in the over 60s, and that has not risen as high on this occasion. Next thing I'd want to point out is that our testing rate is also falling. Obviously, lateral flow tests are available to the general public, and we encourage you to use them at least twice a week. And there's guidance as to when you may need to then do a PCR test. So testing availability is there. No restrictions on that. Compared with other parts of the country, Birmingham is again not where we'd like to be. So we then look to see, well, what does that mean within Birmingham? And what we're seeing is that there are a few areas, but it's not whole wards. So it's getting into quite a lot of detail as to where the pressure is at the moment in terms of positive cases. So we continue our engagement work there. A big part of that engagement work is through our COVID champions, but it's also through all the other people who have contacts with the general public and are able to have conversations about taking up tests when you need to, isolating when you need to, and what support is available for them, as well as taking up the vaccine. So just expanding a bit more on the vaccine. Before I come to the vaccine, just talking about variants of concern. So we're using the Greek alphabet, and the dominant variant we've had for a while now has been the Delta variant. There have been other variants identified, and our colleagues in Public Health England and other parts of our surveillance system are keeping a close eye on this. The positive news, the good news thus far, is that the prevention measures that we have used for all the variants to date remain the prevention measures that we need to use for what we know at the moment. So that means we're still asking people to maintain an appropriate distance, to wash their hands, to wear a mask where they feel that's appropriate or where it's required, and to take up the vaccine. So that leads me on neatly to the vaccine, which the implementation of which has really been led by our colleagues in the NHS. And they've done an excellent job. The main highlight for us is that we are now looking at vaccinating younger people. So we've had vaccination now extended to our 12 to 15-year-olds, and that will start. That will get started later this month. The 15 to 17-year-olds, 16, 17-year-olds have had their vaccine out there. We're trying to encourage take-up. So at the moment, we've got the highest take-up amongst our older population, particularly over 60s, over 80s especially. And what we're looking to do is to get the rest of our population to take up vaccine to the same extent. The interim goal is to get to 75%. At the moment, about 20% of our wards have achieved that. But obviously we've got more work to do, and that's continuing. I'll pause there and take any questions.
Mary, I don't think you've got any questions today. I think everyone is a little bit tired or sick of hearing, or I don't know, but we've got no questions today. So Mary, on that note, if you have no questions, I will hand straight over. I thank you, and I'd like to hand straight over to Morag Gates, the project director for University Hospitals Birmingham Foundation Trust, and she will give, and you'll give a verbal update on COVID-19 vaccination update to include flu, COVID vaccination rollout for 21-22. And then straight after, if Dr. Munir is in the room, can I ask him to do the same for West Birmingham, please? Over to you, Morag.
So, Councillor, I'm going to do my stunning Morag Gates impersonation, if that's okay.
Paul, are you here giving sorry, I thought we were giving you a break today. Okay,
you were, but Morag's gone off to do something else, so I've said I would step in and do it. I mean, quite a lot of it's been covered by Mary already, really. You know, we're still pressing as we can to get people to take up the vaccine for the first time. You've referenced the incredible hard work that's gone on around trying to encourage people in social care to come forward for the vaccine. We've now got a work in place with the 12 to 15-year-olds. We've got the booster program. 1 million texts and letters have gone out for the first tranche in the booster program. So that's getting you back into the swing again as well. In terms of flu, the there's been a bit of a bump in the road around supply at the moment, and we're hoping that will improve, because we've had to actually cancel some of the sessions that were booked. So you were lucky to get yours. We had to cancel some of the flu sessions because the supply hasn't come through. We're hoping that will improve. What we're trying to do now is to move to a much more business as usual approach to vaccine. We've had this fantastic campaign. We've delivered over 1.5 million COVID immunisations, for instance, over these last 9 months. But we need to get to a much more business as usual approach to this. We need to deal with the business of vaccine resistance, because very often the people who are resistant to COVID vaccines were resistant to other vaccines. And Sarah Jane Marsh will be picking that up as she takes on the lead role for immunisation with my departure. So we're going to keep pushing at vaccination, because as Mary would tell you, and as anybody would tell you in public health, vaccination is one of the few things that we do that we really know really works. Thank you, Councillor.
Thank you. Dr. Munir Aslam? Can I ask you to, hello, Dr. Munir, can I ask you to give your report, please?
Yeah, hi, sorry. Let me sort out my tech a little bit, 1 second. Hi, yeah, that should be hopefully clearer. There's not much more to add to what Paul added. We're working ourselves up for the flu campaign. We have had some challenges around delivery of that. We've got lots more practices signed up to deliver the COVID booster vaccines as well. So we feel confident that we're in a position to, all those people that want to have a vaccine can have a vaccine. We know that there are some vaccines currently being delivered into pharmacies. So if you have the opportunity to get to a pharmacy and have your flu vaccine, please go and have your flu vaccine. We are taking the opportunity while there are delays in the distribution of the flu vaccine to encourage people to get and have their flu vaccine as soon as they can. So we've got some challenges ahead, but I think we're in a reasonably comfortable position. Well, not comfortable position, but a reasonable position to meet those challenges head on. We've stood up our hospital site at City Hospital, and that will deliver some of the younger cohorts of the COVID vaccination, as well as those people that have not currently had any vaccination. They will be encouraged to go, and we have a walk-in service there that enables that to happen. We'll keep a watchful eye on the current scenario, just in terms of where we get to in the next couple of months, just to think about the flexibility that we need to show for those people that need to have a more flexible approach to vaccination. But yeah, I think that's where we are at the moment. We've got lots to do alongside the vaccination campaign in terms of recovering general practice and recovery within the wider NHS system as well. So there's plenty to do, and we've had we're focused on the vaccination. But like Paul said, it needs to become business as usual. It needs to be part of the programme that we deliver on a regular basis alongside all of the other work as well, because actually abandoning one just leads to a build-up of in other areas, and we can't afford to do that any longer. I hope that's helpful, Councillor.
Thank you for that, both. I've got two very quick questions. They may seem silly, but I'm going to ask them anyway. The first question, read the 12 to 15-year-olds or 12 to 15-year-olds. Has that programme actually started in Birmingham and across Solihull? But in Birmingham.
It has, Chair, because I've got a bar chart in a presentation I was given earlier today that shows a small kind of number that we've done so far. It's early days, but it has started. It has started.
Yeah. And my second question, and it may seem like a silly question, but I am going to ask it. I had the AstraZeneca vaccine. When I go back, if they invite me back for a booster, will I be getting the AstraZeneca again, or will I be getting Pfizer? Because the news has been saying that people that have had the AstraZeneca may not be allowed into America.
I think that's a medical question, Munir.
Munir?
So it's kind of a medical question, but it's also a political question, isn't it? So the booster will be the advice that we're given in the booster is going to be one of either Pfizer or Moderna. So we'll be one of the mRNA vaccines. The question around so that's the booster that you'll get. With regards being let into America, I think the news came a little bit on the hoof. So they haven't really thought about the detail that sits underneath it, just in terms of how their own CDC will be able to validate the vaccines that have been approved by other health authorities around the world. I don't think they've thought that through. And clearly the AstraZeneca one poses a particular problem for Americans because they haven't used AstraZeneca at all. So I think there is a challenge there for them to work through. My understanding is that the EU are lobbying strongly to make sure that the AZ vaccine is approved for travellers from Europe, and actually it's a very effective vaccine. So let's be clear about that. It's an effective vaccine against COVID. Yes, you can pick up COVID and the new variants having had a vaccination or any vaccination, but your symptoms will be mild and much milder and are less likely to require hospitalisation. So I hope that partly answers your question. The politics, I'm afraid, Councillor, you're a stronger area than me to deal with that. But generally, I think they haven't thought through. They've made a big statement, but they haven't thought through the implications of the different vaccines around the world.
Thank you. That answer is actually really helpful. Does anybody have any more points or questions or any other before I thank these two beautiful gentlemen and move on? Well, I've had no hands up. So what I'll do, I'd just like to say, Paul and Dr. Munir, thank you so much for your points, and we'll move swiftly on. Thank you very much. Now, the next item on the agenda is Eve Buckland, the chair of Birmingham and Solihull ICS, who will give a verbal update on the ICS and where we're at the moment. Eve, are you in the room? Silence. Stacey, do you know if Eve has been told? Does she know she had to give this?
I believe so, Councillor Hamilton, but let me just check. Bear with me.
But what we'll do is we'll move swiftly on because we don't want to fall behind. Okay, so if you check if Eve is coming in, we can, because it is a little bit earlier, we were ahead of ourselves. The next item is Dr. Mary, who will be talking about the Commonwealth Games, and she'll be giving us a brief update of where the Commonwealth Games is at and how we've been involved. Okay, Mary, over to you.
Thank you. Just finding the buttons to press. Okay, so obviously most persons will be aware that we have passed that key milestone of 1 year to go. So it really is an exciting countdown now. There has been a huge amount of work in terms of preparation, and that has been changed and modified to accommodate the fact that we've been also going through a pandemic in recent times. There's several strands to the work of the Commonwealth Games preparation. The first part to mention is that there's all the work around having a successful, safe games, and that is successful for the athletes and their families, and that includes the officials, but also for our residents and our visitors who will be attending those games events. The second strand to the Commonwealth Games work is around the legacy. And again, a huge amount of work in terms of how we can embed that legacy, get as much of it in place before the games, and going on through and beyond the games. If I were to expand on those just a little bit more, it's a multi-agency approach. This is not about Birmingham City Council alone or the organising committee alone. It involves working with a range of agencies from Public Health England, liaising with the NHS in terms of preparedness, checking that our emergency resilience arrangements are in place, for any of the surprises that we think we may have to deal with, right the way through to how do we procure supplies for the games infrastructure and the consumables that are required. So some of that work has involved looking to make sure that this Games does well for Birmingham as well as the region around Birmingham. That involves things like getting our procurement to consider how we can develop opportunities for local businesses to meet the necessary standards and to participate in the progress towards a successful Games. I didn't want to go through in too much detail, but I think that would be an overview, and I can take any questions you have.
Sorry, Mary, I just got thrown out of the meeting. So has anybody got any questions? Can I, Dr. Aslam?
Thank you, Councillor. So, Mary, this is a great opportunity for children in this city to have an opportunity to look at elite sports. They've watched the Olympics many times, and the Commonwealth Games is a real opportunity to engage young people in sporting activity. We know we have an obesity crisis within our young people. We have it within our older people as well, but within our young people. I just wonder what the engagement has been with schools and with the wider young people communities to engage them in sports so that we can make the best of this opportunity, because part of the legacy is the excitement of leading up to this, but then what it leaves with us behind.
Yeah, really good point made. So yes, there are lots of opportunities for young people. One of those is around physical activity, but that is actually, we're taking an all age approach to it because we recognise that young people are part of families. So there will be some things for young people, but there will be some things for all ages as well. And that's built into how we're organising access, for example, to the facilities, building in active travel as much as we're able to, but also as part of our legacy. I'd have to come back to the board on the issue of schools, where we're doing things through schools, but we are doing things through our communities and accessing young people to increase activity as part of life, not just structured physical activity.
Thank you for that, Mary. Graham, would you like to make your point or ask your question? Thank you.
Well, it's almost an answer to Munir's point, really. I think it is important that there's so many dimensions to that, and the point you raised, Munir, is absolutely right. That's got to be one of them, isn't it? It's such an opportunity. But I also think when we're thinking about the legacy, we should be thinking about the infrastructure. So I think it's important that we think about cycle routes and all of those kind of things as well, which are almost the underpinning things, really, to input. And you're probably aware, and other colleagues are probably aware, we are in the process of appointing a new director of children's services, and certainly I was involved in setting the framework for that new role, and part of it is absolutely about the opportunity of the Commonwealth Games for children and young people in the city. So it's a very good point. I hope that adds to the thinking as well. Thank you.
Thanks for that, Graham. Really interesting point. And thanks for your point, Dr. Munir. Any other points? I'd just like to add, the Commonwealth Games is a once in a lifetime event. We will never see it again in Birmingham, not in my lifetime. And I do think it is a really brilliant opportunity for us. It's not just about the 10 or 15 days that it will have the madness going on in Birmingham. It is really about the legacy that will come before and that will be created for after. So all I can say to people on the Health and Wellbeing Board is be part of it. So I haven't heard anything from people like Kerry, who sits on CFA Fireside, who's the chair. I've heard nothing from BW. Oh, I've forgotten the names today. The voluntary agency. Nothing from Health Watch. What are we doing as a community to ensure we're taking part and being involved? And I absolutely agree with what's been said. It's not just about the council. If it's just about the council, we've lost it. We will not get the legacy we require. The local community have to take ownership of this. And that's what I'm hoping as the months go on and it becomes more exciting, because I think Graham may have the answer to this. Is it 25,000 people that have applied to be volunteers, Graham?
Yeah, that's correct, Councillor Hamilton.
Yeah.
The response has been phenomenal, really.
Yeah. So we've had over 25,000 people that have actually applied to be volunteers. So as part of the board, we're putting this on as a standard item, because we want to see across the areas that the board influence, what are we doing to be part of that legacy going forward. So Mary, I want to thank you. Hopefully in the next few months, when you do come back, people will have more to say and they will grasp the nettle, because it is so important what is about to happen to this city. Dr. Munir, did you want to come back in, or can I move to the next slide?
I was just going to say, Councillor, it's an excellent point that you've made there about engagement, isn't it? And I think that the first that I've heard about the Commonwealth Games is in this forum. So we haven't really had the communications and out to primary care in a way that is meaningful. And I think we could get a lot of engagement, not just in young people, but across the spectrum, to be volunteers, to be creative about how they support the programme as well. So if there's some way that we can help, we would absolutely love to do that.
Fantastic, Dr. Munir. Graham, you've come back in.
Yeah, I mean, if I can help with that, I can speak to Craig Cooper about how we ensure colleagues in primary care are more engaged. I mean, it's really great that the offer's been made, so let's follow it through and we'll make sure we engage in lots of different ways. It's really helpful. Thank you.
Thank you. Thank you for that, Graham. Really helpful. And on that note, can I thank you, Mary, for coming today and discussing that item. And we're going to go backwards. We'll go back to the item before, the item 12, the ICS update. Eve has been put down, Eve Buckland, as the person to give the verbal update, but it will be Richard Kirby. So Richard, over to you. Thank you, Richard.
Thank you, Councillor Hamilton. My apologies for not being Eve Buckland. I appreciate I will be potentially a poor substitute, but just a few things I think to share about the ICS and its development. So we're at a point, of course, as Paul kind of hands over the baton to a new ICS chief exec to be appointed in the next month or so, of getting the kind of all of the things that, you know, the systems and the processes and the plumbing and the wiring that we will need to make the ICS work effectively. And in particularly, I think for the Health and Wellbeing Board, that includes some hard thinking about how we want to work through the two places that are the City of Birmingham and the Borough of Solihull, and how within Birmingham we want to make the operational partnerships a reality at the 5 localities as well. And Graham, with other colleagues, is leading some of that work, and I suspect we'll want to share that at the Health and Wellbeing Board at the right point. If you then step back a bit from all of the work that's going on to manage the transition and get the ICS set up as a statutory body, I think there's probably just two things to say around two big pieces of work that are on the agenda. So in the here and now, the partners in the ICS are working really hard about how we get the health and care system safely through the winter and into the start of next year. You know, we've got some big elective backlogs. There is some real COVID-19 emergency pressure in the system. There is pressure from emergency work that didn't come through during lockdowns that is coming through, and we know we've got to respond to all of that. We can't kind of just do one bit of it and not the rest of it. So there's some work going on that should be completed around the end of November to pull all of the strands of that together into a coherent short-term plan for our health and care system, and I'm happy to talk a bit more about that if that's of interest. The second big piece of work then is to look to the long term, and it links a bit, I think, to the conversation we've just been having about the Commonwealth Games, because it's about building then a sustainable system that picks up some of the things we will be coming to later on the agenda around the role of the ICS in tackling inequalities and improving life chances, the role of the ICS in building a proper population health management way of working that starts to tackle some of those really deep-seated causes of ill health and inequality in health outcome, and enables us to, having got through the current period, to look forward, I think, to a more sustainable future for health and care services in the city, which is based on doing what Doug Simkis, who's, I don't think he's here today, but he's often here, would call tackling the causes of the causes. So trying to work across the whole system on those things that really enable people to stay healthy, and that should take the form of the kind of ICS 5-year strategy early in the new financial year. So that's kind of where we are. There's a lot going on. Quite a bit of it's in the background, but those two big bits of work around kind of getting the system safely through the next 3 to 6 months, and then picking up what that sustainable future looks like are where the effort and the energy is at. Lots of people who are in this meeting are really important parts of all of that work, and I'm sure would speak to their particular parts of it if we need them to. So I hope that helps.
That's really helpful. I would just like to say I've been part of that work, and I have to say social care and the local councils have not been left out of any bits of it. It is important, as the months go by, that the Health and Wellbeing Board is very clear on where it sees itself and where it wants to position itself, because we are a valuable part of what is happening within the health and care system. So it is important that through the Health and Wellbeing Board, the messages are sent back to the not STP, to the ICS, so they actually know. And I'm really delighted that Stephen Raybould has come in, because I'll let him speak, because it is important that that sector has a voice. So Stephen, over to you.
So we've been involved in planning the voluntary sector involvement in the ICS, and that's gone reasonably well, and it's about to be stood up with the rest of the activity. 2 things would be really useful. I think a system map, so that we can see the governance routes that incorporate all the things that currently relate to it, and then and perhaps this isn't the right forum, but a maturity update around the ICS, so we know when to stand up different structures within the voluntary sector, so that they're met with something within the ICS, and just getting the timing of that right would be really important to it being productive.
Richard?
I mean, I think Stephen makes 2 really important points, and the wider work we're trying to do won't work if we don't manage to engage Stephen and his colleagues. We are still designing that system map ourselves, but there is something called the ICS target operating model, which is, I'm afraid, an awful bit of NHS jargon, but it broadly kind of means how we want to try to make the system work. And if it would help, I could organise the right group of people to share that in a bit more detail at a future Health and Wellbeing Board meeting, if that's valuable here, or separately with Stephen, if that or both. I'm happy to be guided.
Thank you, Stephen. Do you want to say anything else, or can I?
That would really be helpful. I'll leave it to the chair as to whether that's the board or somewhere else.
Right. For myself, it depends on how long it will take. If it's something where we need to go into detail, perhaps it would require a separate meeting, because, to be totally honest, nothing about ICS is easy to grasp. It all seems to be, nothing is simple, because to be honest, the stuff coming from government is so light touch. Nothing is simple. But what we've been able to do at this system, Birmingham and Solihull, at least we're having the difficult discussions. We're having them early, and we're starting to put together a structure. We may need an away day or some sort of a development day of the Health and Wellbeing Board for that to work. But as the months go on, we will let you know. At this moment in time, nothing's been decided, but I do think we're going to need a development day so that the people who sit on the Health and Wellbeing Board actually understand how we have a very important part to play in what's going on. And on that note, I feel as if I'm talking too much, so I will move on directly to the next item. And thank you for that, Richard. Thank you, that's really helpful. The next item is the population health management, and that is Dr. Dina. Dr. Dina, are you with us?
Yes, thank you, Councillor Hamilton, and good afternoon, everybody. As I understand from Tracy, you'd like me to take that this paper has been read, and I'll only summarize the purpose of the paper and talk briefly about population health management, which should just take a few minutes. The update informs the board of the important role of population health management in improving the health outcomes and reducing inequalities of an entire population. The update also highlights the responsibilities of all local authorities through their directors of public health to inform and guide integrated care systems partners as they seek to implement population health management. And thirdly, the paper updates the board on the various pieces of work that's been undertaken to ensure that Birmingham Council has the capacity and the capability to support local population health management implementation. The activities within population health management use individual and population level data that relates to both health outcomes and the wider determinants of health, such as socioeconomics data and qualitative information from citizens and the community. Applying analytical techniques, including segmentation, stratification, and modeling, population health management can, for example, be used to identify local cohorts within the community who are at an increased risk of poor health from specific conditions. Services and care pathways can then be designed and, where appropriate, implemented in a targeted manner to prevent or intervene early for those individuals so as to ensure improved outcomes and prevent inequalities. So hence, population health management is in line with Birmingham City Council's policy ambitions to move from crisis to prevention and its commitment to addressing inequalities. The same ambition is included in the NHS long-term plan, and it is articulated by stating that the ICS partners will implement population health management to move the NHS from reactive to preventive programs. Within the plan and reflected in the guidance to the NHS organisations is the expectations that the public health experts, specifically local authority directors of public health, will support and inform, guide guide the approaches to population health management. In view of the expectations, the public health team, in collaboration with the other divisions and with the local partners, have been implementing a population health management work stream. As population health management relies heavily on advanced information technology, particularly those requiring capabilities in big data techniques, the public health team will require additional resources to undertake significant work in this area. Included in the aims of the work stream, therefore, is the goal of ensuring that the required levels of capability and capacity for population health is available to the Council. The work streams involve activities in two areas. The first area being scoping to understand local views on population health management, to understand the available evidence and the adequacy of local assets for population health management delivery. And then the second area of work is enabling readiness and building capacity. So as I was about to just take a few minutes, I'll stop there. The paper includes details of the various activities within each of these two areas. Thank
you for that. And have I got your name right?
Dinah.
Dinah?
That's
Have
right.
I got that right? Okay. Thank you for that. Will Taylor has got the first question, but Will is going to come in, and so is Dr. Aslam, but I want to just pose a question to you. You skipped over a really important piece of work that you're doing relating to the first 1,001 days and item 4.3.4, which for me is one of the most important pieces of work in the document. You don't have to answer it straight away, but I'd like you to tell the board a little bit more where you've got to, what you're doing. I know you've highlighted some of it in the appendix, but some key points would be important because this work is being driven through, and there's a lot of good things going on in that specific area. So Will, over to you, and then Dr. Aslam. Will?
I think this is an idea. It's a great piece of work actually, and it's come at the right point in the agenda actually, because it comes after we've talked about the health inequalities issues that we're seeing across the city. We talked a little bit about place and how we can use place to really tackle those health inequalities, and having the population health management data to support that work in place is going to be absolutely vital. And we've talked a little about how ICS is developing that collaboration between health and social care. And then a little bit about the sort of wider determinants of health associated around the Commonwealth Games. So there's a couple of things that I was quite interested in knowing. And one of the things I talked a bit about when there's been a bit of a round about interviews around population management, and it's in the presentation that you sent out alongside the agenda. I've always butted against, when I've been trying to do things, the issue around combining data sets. Which is going to be absolutely vital, especially across health and social care. And one of my questions was there's a bit about fuzzy data, which I don't fully understand in the presentation, about doing that. How's that going? Because I think that's going to be absolutely key. And the other thing was, and I suspect because of COVID, we haven't really done as much as we can. And I think this came across earlier about the benefits of the Commonwealth Games. Is there an opportunity here to actually use the Commonwealth Games and the data we have around physical activity, the improvements of physical activity can have on health, and some of the inequalities in that, actually as a launch pad, as one of the early projects of some of our population health management data, and actually use the Commonwealth Games as a bit of a launch pad for that.
Before I bring Dr. Aslam in, do you want to answer some of those questions? Because I think you may forget them if you don't answer them. And Stephen,
it was data and Commonwealth Games.
Yeah.
Data, yes. The data is, as I've put in the update, it is a major issue. There are major information governance issues around getting agreements to be able to share the data. And then, of course, there are some technical issues around the fuzzy data, which is, I think those are more surmountable. But the issues around getting the agreement from the various partners to share the data, I think is a bigger hurdle that we have to overcome. And particularly at this time, given what has happened happened nationally concerning the upload of primary care data, that is presenting huge problems for the work. But I think these are problems which nationally will be overcome eventually, and we're trying to work hard to be in the position that when the time comes, we're in a position to make use of all the available data. So that's the question about does that help?
Yes. Oh, sorry, I mute myself. Yes, thank you.
And your suggestion around using the Commonwealth Games, I think that's a brilliant suggestion. And that's something I think we would really like to explore, maybe with yourselves and with others, because the two projects that the two pilot projects, one is around infant mortality, the other one is on obesity and weight management. But I think what you've just suggested sounds something that we should definitely look into, and I think would be hugely beneficial. So thank you for that.
Brilliant, thanks.
Thank you, Will. Can we go straight over to Dr. Munir and then Stephen, please?
Dinah, I'm a data geek as well, so I'm interested in the data, and I think it should drive our decision making and enable us to understand whether we're achieving some of the things we want to achieve. We've got the biggest local authority in Europe, in Birmingham City Council, and we've struggled to separate the data for West Birmingham so that we can start adopting a data management driven approach in West Birmingham. How can we unpick that? Do you recognise that there's an issue, and then how do we unpick it so that we can start, so that we can get on with the population health approach?
Yeah, I do recognise it's a problem, but it's not a problem just to West Birmingham, because I mean the ICS approach is very much place based. And therefore, within Birmingham, each of the localities will have to grapple with the same issue. So that is true. And I'm afraid I'm not a data expert. I'm more in public health and health economics. So these are some of the reasons why we are trying to get in place those who have that capability to help us with this sort of technical issues. So I'm not able to give you the answer, but it is something that we recognise. And that's one of the reasons why we're going through this work stream and trying to put certain capabilities in place.
Councillor, I just would like to highlight that it is a problem in West Birmingham. We can't separate the West Birmingham data into its own data sets, which means that some of the interventions that we're making we can't track. We would like to do that. So if we can help to unpick some of the challenges, then we'll help. But we need to work together to do that.
Yeah, definitely.
Dr. Aslam, you raise a really interesting point, and I don't know if Graham is still on the call or Paul. I know Paul Jennings. Paul, has any work been done, or Graham, to try and unpick some of these figures? Richard, brilliant. Or even, yeah, no, Graham, over to you. Then Richard would be fantastic.
Oh, I wasn't going to contribute much apart from to say I'm not aware, but I can take it away. But it'd probably be better to hear from Richard first, and then.
Okay, Richard, over to you. Stephen, we haven't forgotten you, I promise. Richard? Over. Richard?
Let me take myself off mute. Thank you, Councillor Hamilton. I think two things to say. I mean, yeah, can you hear me? Okay.
No, you keep cutting out.
I think there's two things to say. Okay.
We can hear you.
If you can't hear me, I'll. Okay.
No, we can
just two
hear
things
you.
To say. I mean, good. When West Birmingham moves ICS, some of the splitting up the NHS data issues will be easier. So it's maybe a bit of a time limited problem that Munir is describing. But then there's also some work that I know we've got to bring to a conclusion, particularly with primary care around data sharing, and that I mean, I was involved in some conversations about that this morning. So we're trying to get some of the difficulties that people are talking about straightened out as quickly as we can, though there are some complex things behind it. So we're on the case, I think, is probably the short answer.
Okay, Richard, thank you for that. Dr. Munir, I think Paul, have you got anything you want to add?
I was just adding a thumbs up to what Richard said, Chair.
Oh, all right, thank you for that, Paul. Graham, did you want to round that up before we say goodbye?
Yeah, we will be saying goodbye in a minute. Yeah,
I know you'll be going in a minute.
I think people are right. There is work to be done. What's good is that it's been flagged up now, and we can really begin to get a handle on it. So I think, as Richard and others have said, it is positive that we can move forward in that way, and that's the intention now. So we will follow that through, Councillor Hamilton.
Fantastic, because I do think if you can't get the figures for the areas, how are you knowing how you're dealing with things in each part of the system? So thank you for that, really helpful. Stephen, you've got the last question or point for Dana.
So just to come back on the previous points, I think West Birmingham does offer a good opportunity to start somewhere if you're thinking about a locality within Birmingham because of their ICP governance there. So it's a good opportunity to test. My request really is that population health management is one of the things that the voluntary sector can contribute to, but it's very difficult if the presentation of the challenges are particularly technical. And one of the things that would be particularly useful is just straightforward requests around what is needed, and that the voluntary sector is thought about as a specific audience for that.
Dana? Thank you, Stephen. Dana, you've got your mute button on. Could I ask you to take your mute button off, right, and respond to Stephen? Thank you.
Yeah, Stephen, that's a very good point. As I mentioned, the quantitative and qualitative data, qualitative data in particular from the users and the community is really an important part of the data that population health management has to use. And I think it's quite appropriate that we strive to make sure that the population and citizens are aware of what population management can offer, so that they can participate in the appropriate way. And I think that's one of the things that we're part of the work stream that we're undertaking. And I'll definitely be in touch so that we can have your input on how best to do that.
So, Stephen, I think you've got a lot of work will be coming your way through the questions you've asked this afternoon. So on that note, can I thank you, Dana? That was a really interesting topic. Now, I haven't forgotten the question I asked. The thing about the 1,001 days.
You would like me to talk about that? Do we have time?
Just 2 minutes. Just talk a little bit about that, because I think for me that is a really important piece of work.
Yes, I think we're all aware of the challenges about our rate of infant mortality. And the work that we'll be doing in population health management will be looking at the data in order to support what the infant mortality work that is currently being undertaken in the council. We have a workshop actually which is going on right now, which brought together many of the very experienced people in that field, the geneticists, the clinicians, the community providers, those who are working on CDOP, that is the Child Death Overview Panel. All of those individuals are currently trying to put together a strategy that will allow us to tackle that. And the population health management will be providing the data to support some of the work that they're doing.
No. That's what I wanted you to just bring that across. Also, just to let people know, as Birmingham City Council, we've got an independent chair for that piece of work, and that chair will be helping to drive that work forward. And whatever we get as a final outcome, we will be ensuring that what we get is implemented within the system. It is really important to understand that for us in Birmingham City Council and the partners, this is a key piece of work right now. Okay, and on that note, can I thank you? Brilliant, and I'll speak to you soon. Okay, we'll move on to our next agenda item. And before we do that, recommendation 3.1, is that agreed by the members? Is it not agreed? Do you wish to abstain?
Agreed.
Agreed, thank you. If you just put something into the chat, at least I don't feel as if I'm talking to myself. Thank you, that is fantastic. Now, can we move on to the next item, which is Dr. Andrew Dalton. He will be talking about screening and immunization. Dr. Dalton, are you here?
Yes, I'm indeed.
Okay, can I hand over to yourself, please?
Well, thank you, Councillor Hamilton. Thank you, everybody.
Pleasure.
As previously, I'm not going to go into the report into too much details. I'll just give a brief summary and then be here for any questions or points of clarification or further conversation. So in the national screening and immunisation programmes over the last, well, sort of 18 months now, it has been a case, as with elsewhere in the health system, of getting through COVID and then recovering. Different programs, as I've said previously, have been hit differently by the heart of the COVID spikes over the last 18 months. Some programs stopped altogether, but some carried on pretty much as normal, especially in the antenatal newborn, and some carried on but at a reduced rate. I think the really important thing as well is that even when some of these programs started back up in summer 2020, they weren't necessarily running at the capacity they would normally need to do to screen people every 3 years, 5 years, whatever the recommended interval is, to do with the COVID infection prevention control measures. So it's all been about what we're calling restoration and recovery, and those have been the words that we've said a lot across the NHS this last few years, year and a half. So some programs have made great progress. So cervical screening largely are back up to where people will be invited at the normal intervals. Some programs been a bit slow and a bit harder to recover. So breast screening, AAA program, the diabetic eye screening program, would have got plans in place to have caught up with their screening backlogs by March next year. And the providers in your area are pretty much on track. A couple of need a bit more conversation, perhaps a bit more support, but some really good pictures there. And lots of hard work from the providers themselves in terms of the recovery. Again, across immunisation, different parts of the programs have been affected differently. The primary immunisations didn't stop, but we have some evidence that there was reduced uptake through parts of 2020. Others stopped altogether, so the school age programs stopped, and then they had to recover through until now. I think the big thing that when I was asked to come, you wanted me to touch on was around the equity and the kind of more proactive stuff that's more proactive in terms of improving uptake. So I think in some of the screening programs there has been not as much focus on that for a period of time, given that the providers really had to get a program up and running. They've been looking to restore equitably, but perhaps not the efforts that we've done previously to go out and promote uptake. I think for us now as kind of commissioners and partners, that time's really coming to an end. So once you've recovered, it's really getting back to that agenda. That will, I think, take a lot of learning from the COVID vaccine programme. I think there's some implications for that from screening and obviously the rest of immunisations for some of the good things that we've done there. With immunisations, I'll probably say one last thing before I answer any questions. There's been a real change in focus that the COVID programme has brought about. It's the idea of system ownership. So as regional commissioner, I see myself as part of your system. I'm lucky to have two systems in Black Country as well, but very much part of the systems. So the systems obviously delivered COVID vaccine, it delivered the last two series of flu vaccines. So it's that transitioning to really have some oversight and some leadership in the whole of immunisations with other partners. So your, I know at the minute you've got two ICSs, but the BSOL ICS is setting for board to cover all immunisations. We'll meet very soon. Really looking at some of the efforts and work that we need to know around coverage and uptake in primary immunisation, for example, that working with that board to really get that done closer to the people that need it in the best way for your population. I think that's been a huge, a really big change in the last 2 years, and something that I really think will be a good thing in terms of how the oversight and the delivery of all of immunisations is. Got some ideas of projects that group can potentially take up as first project to ensure that we can work in this field. I'll leave it there if that's okay. I agree.
That's fine. Have I got any questions or any points? Will, can I hand straight over to yourself?
Yeah, so I think it's great, Andrew. Thanks for coming along. I think, you know, both screening and vaccinations are sometimes the less glamorous part of the NHS and what we do and the NHS family, and yet undoubtedly saves more lives than almost anything else we do across health, which is really interesting. And all credit to you for the work you've been doing to try and get these back on track after a difficult time during COVID. I mean, there's some really great bits of work in the paper you've shared. And actually the bits about learning from the COVID vaccination program, actually, you know, that could revolutionize, I think, how we deliver vaccination programs if we are quick enough to learn the lessons we've learned from it. I guess my only point was the paper you shared, there were some quite big gaps in terms of data. There was quite a few sentences saying there's no published data to indicate screening uptake following the COVID pause. I just wondered when we're likely to know a little bit more about what the backlog is and when that data is going to come online, so we can see the implications of the actions you guys have been taking to try and improve things post-COVID.
That's a good question, and I suppose anyone that's done any work in screening knows that these national data are delayed, and it's something that we say is an issue for the national team. Any lobbying anyone can do on that is welcome. It varies between programs, so to get validated data in breast screening, it tends to be about 6 quarters, so it's quite a delay in it. It's a problem. I can only apologise, and it's not. Hope it's not my fault.
No.
But it's difficult.
6 quarters is quite amazing, actually. That delay is
it's there. About the validation and it's the way it's extracted from the national databases.
Yeah.
Hopefully, I suppose there's been a lot of criticism of the national screening databases, and the independent review of screening nationally highlighted those problems.
Yeah.
There's been a national plan to change those and renew those, so hopefully that'll improve things.
Yeah, it just makes planning and strategy a little bit more difficult, but thank you.
Could I, I'm going to bring you in, Dr. Aslam, but could I ask a question just following on from Will? I know that there's quite a lot of gaps. Are there any plans from your neck of the woods to sort of publish even partial data as you start to receive it? Because the gaps are quite, I won't say astonishing, but there are quite a lot of gaps there, which at some point somebody is going to have to take ownership of it and at least try to delve into it.
I think some of the immunisation data are getting more timely, so there's been progress on that, and that's something that we do have a bit more up to date. I think for screening, I can look into it, what we can and can't, what there is to share and what there isn't. We absolutely want to, and I think in cervical screening we've hopefully got some agreement where we can get some data to a general practice level to get a much more within the last quarter idea of what your coverage is, so then colleagues in general practice can decide if they need to really promote it in their area. So it is coming, the improvement program by program, but not systematically.
And then this is just my last point. Will people that have missed be called back? Are they being picked up and being called back?
Absolutely. So that's why recovery has been so hard. It's not just about getting the 30 to 100%. To recover, you need to work at 150% for half a year to catch up. And that's what the programs are doing. So cervical screening, for example, everybody who missed has been invited. Breast screening providers have to have done that by 31st of March. So that is absolutely what restoration is. So no one will miss it. They will just have their interval altered in between screens because of the COVID stoppage.
Okay, I'll hand you over to Dr. Mania Aslam. Doctor, over to you.
Thank you, Councillor. It's fair to say we know a lot more about vaccination and people's challenges around vaccination now than we did before. I was just looking at the children's immunisations here, and particularly the MMR. We've always been challenged, but it doesn't look like a data problem. It just looks like a lack of MMR in kids' arms at the moment. So are we going to learn the lessons quick enough to get these vaccination rates up, or what do you think a recovery looks like? Because this is, if you look at the national data for England and then West Midlands, we are a significant outlier. We've always been. But my main concern was that, you know, the vaccination programme would just highlight vaccination as an area that people don't want, and then that would spread into children's services as well. So that would be a genuine concern of mine.
Right, we've got, if you want to, you can either answer Dr. Aslam's question now, or we've got another person wanting to speak. Mary.
I'll let Mary come in first.
Okay, Mary, can you come in, please?
Yeah, so thank you for that, Councillor Hamilton. It's part question and part of point to raise. So we are aware that our childhood immunisation uptake rates are not where we'd like them to be. And there was a piece of work done as a system level just shortly after the first tranche of COVID vaccines to see what have we learnt from doing the COVID vaccines and how we might use that for immunisations more broadly. I think my ask here is for our colleagues in the NHS system who showed real enthusiasm shortly after that, because they could see the difference it had made to COVID vaccines, to really bite the bullet and say, shall we do this for MMR? So in conversations, there's been lots of interest, and it's how can we learn the lessons and how can we apply that to ongoing COVID vaccine and flu vaccine? And the big ask from me, and I would ask it as a public health physician, is that we extend that to MMR and other immunisations. We can see the short-term benefit to the NHS system of getting flu jabs. We can see the short-term benefit to the NHS system of COVID vaccines. When you get to the other parts of immunisation, it's not as immediate a payoff, but somehow we've got to tap into that passion and all of that knowledge. And so I keep pushing that we look at MMR and see what we can learn from COVID and translate to MMR. So there's a piece of work which we are just about to do within Birmingham, working with our COVID champions to see how we can help use them to develop the messaging to reach bits of our community that we have not previously reached. Because the offer is there. What we want is a queue of young people with arms to be jabbed. And so we're looking to develop that toolkit. So I just thought I'd share that information. We are aware, we are trying other methods in addition to all the things that Andrew's talked about.
Mary, that's really, really useful information. And on that note, Andrew, do you want to come back with any final comments, and then we'll let you go?
I just think to touch on what Dr. Aslam said, I think Mary partly answered it and partly said the same thing. I do think we'll learn, and I think the ICS is the speed at which their COVID board has become an overarching IMS board is really excellent. So I think it was colleagues on this call that have been directly responsible for that. So I can only thank them, and I look forward to being part of that group. And I suppose for me, it's just the last thing is, with primary immunisation, it's not about recovery. The data that you see isn't because of COVID. It was like that before COVID. So for me, it's about using the learning from COVID as a springboard to get way beyond recovery, and that's hopefully what we will do in start off as of tomorrow when I get back into work.
Right. Really, really interesting. I have to be honest with you. I worry when I see our screening levels, because I'm with Will on this. If if you're not screening enough people at the moment in communities like mine, and I don't know what's being done out there, but I know across all communities, and I can say from communities like mine, I am seeing more and more people dying because they weren't screened early enough for things. More and more women with cervical issues and other issues because they're not being screened early enough. At the moment, it's been masked by COVID and what happened with COVID, but I'm not sure how long that will be the mask because of the amount of people that we are seeing that have passed on. And it would be interesting to see in the death data if there has been an increase over the last 18 months, a significant increase. But as I said, I'm not an expert, but I do think the screening and what you're doing is absolutely vital if we're going to have a community that remains healthy in the long term. Anyway, on that note, Andrew, thank you very much. And thank you, Dr. Aslam. Thank you, Dr. Taylor. And thank you, Mary, for all your responses. Really, really interesting. Thank you. Can we move swiftly on to the JSNA deep dive? Now, Luke Eslop will be talking about this. No, before I do that, let me get this right. Recommendations 3.1, we've got to agree the recommendations. A recommendation 3.1, is that agreed, or does any member not agree or wish to abstain? I just need one person to say something and then put it into the chat. So Will, do you agree?
Agreed.
Great. And if you could just put it into the chat, I'm happy with that. Thank you. We'll go on to the next item, the JSNA deep dive. Luke, are you on the call? Are you here?
Yes, I am. Thank you, Councillor.
Right, Luke, can I hand over to you, please?
Certainly.
Thanks.
So good afternoon, everyone. I'd like to present a progress report on 3 elements of the deep dive programme. These are all in the paper, so I'll assume you've read, but I will provide a brief summary of each. So these are an update on the recommendations of the Veterans Deep Dive Report, an adjustment to the Deep Dive Programme's running order, and a request to the board members for sponsorship. I'll be happy to take questions, of course. So I'll start with the Veterans update. At the last Health and Wellbeing Board meeting back in July, I presented the findings of the Health and Wellbeing of Veterans Deep Dive Report. The board accepted each of the report's recommendations and also requested an update at this meeting from the study team to advise on planned partners and the delivery of the recommendations. Those who were present in the July meeting may recall that a key recommendation of the report is that GP surgeries in Birmingham should be encouraged to gain veteran-friendly accreditation through the Royal College of General Practitioners. It's envisaged that this will enhance our contacts and our engagement with veterans and lead to a greater understanding of their health and wellbeing needs in Birmingham. Now, we've identified the BSOL Hospital Trust as a veteran-friendly registered already, and Dr. Justin Varney has written to the remaining trusts encouraging them to also sign up for accreditation. Additionally, there are now 40 veteran-friendly GP surgeries in Birmingham, and this number is rising, but further work by the ICS is required to fill these gaps. Another central element of that Veterans Deep Dive recommendation, report recommendations, was that the findings should be used to inform a refresh of Birmingham's Armed Forces Community Covenant. I'd like to share with the board that the study team have been invited to present that report to Councillor Cotton and the Armed Forces Covenant group meeting next month, where there will be a discussion about updating the covenant in line with the report's findings. Moving on to the running order update. Now that the deep dive programme is running at capacity, it's become clear that our work sometimes overlaps with commissioning requirements in other areas of the public health division relating specifically to producing needs assessments, and thus it benefits from ordering adjustments. So currently 3 research topics within the current deep dive programme relate directly to commissioning work, and this has led to these topics, which are domestic abuse, learning disabilities and substance misuse, each being elevated up the deep dive programme running order in place of work and worklessness and sexual and reproductive health deep dive topics, which subsequently moved down the running order. For each of the elevated research topics, the first stage is to develop needs assessments for commissioning purposes, after which the research shall be expanded into a deep dive with the additional public engagement that brings. That will be done in early 2022. Additional resources have been leveraged to deliver this work within the required timescale, and subsequently the needs assessments will be updated and enhanced to produce the associated deep dives. Additionally, it has been determined that the public sector workforce deep dive should be removed from the current programme due to the change in working practices during the pandemic. There is a current vacant slot in 2024 where this could be potentially relocated to, or alternatively another research topic could be introduced. And then finally, we also have a request in place for board members to engage as champions to sponsor each of our deep dives. The evidence team would like to secure health and wellbeing board champions for the next 6 research topics that feature in our work during 2021 and 2022. These are learning disabilities and autism. Secondly, dual diagnoses, mental health and misuse of substances. Thirdly, mobility impairment, then domestic abuse, sensory impairment, and diabetes. Champions will need to be health and wellbeing board members, and roles will include challenging the scope and breadth of the deep dives, scoping and agreeing the content with the topic lead, and ensuring that the research drives local commissioning and decision making. I'll pause there for any questions.
Right, Luke, that's excellent. You're not asking for volunteers today, are you? What we'll do, will we write out, and are there any specific members that would fit in certain areas that you will approach first? Or are you just looking for members?
Members with time and the interest. Right. Certainly within the areas that I've mentioned.
Okay, and when will this work start? Will it be April 2022?
Half of them have started already, so that would be pressing. So in the cases of learning disabilities, the mental health and substance misuse, mobility impairment and domestic abuse, that works already right.
Yeah. But the others, when will they start? So I'm absolutely clear.
Absolutely, that will be in the spring of next year.
It will be in the spring of next year. Just a minute. Mary, over to you. Thanks.
Now, I think you've just clarified the point I was going to make, that we need champions now. And yes, some interest and knowledge is great, but enthusiasm is even better, because we do need your eyes looking at this, but also able to help us open doors and make connections where we need to.
Right, we've got, someone's got their hand up, but 1 minute, let me get the list. Carly Jones, and then Richard Kirby.
Yes, just a question on the champions. If you write out, will you provide a little bit more detail about the sort of time commitment and what kind of network you're looking for people to have and that kind of thing? It'd just be helpful to have a bit more detail and exactly what it will entail.
Yes, certainly. I'll actually relate this back to the original documents regarding the deep dive programme. This was the original plan all along, and it got shelved because of the pandemic. So we're reintroducing it. So I'll certainly make that clear.
Thank you.
Thanks. And then Richard, over to you. Richard Kirby.
Thank you. Thank you, Councillor Hamilton. Just 2 quick points. One is that the veterans' work has inspired BCHC to put right the fact that we weren't one of the trusts who were already veteran friendly accredited. So we will do that on the back of this work, and I'll see that through. And secondly, I don't want to jump the gun, but I was the champion for the public sector workforce work that's been stood down, and the trust provides the adult learning disability service for the city. So if you don't get a better offer around learning difficulties, I'd be really happy to fill that gap for you.
That's fantastic. I think they're delighted because you've literally made the first offer. And Stephen Raybould, you've got the last word, question or statement on this one.
So just to say, it would be good to get some more profile around the deep dives. And I know one of the challenges was that there was some of the work being undertaken in different parts of the system, including in the voluntary sector, that meant that some of the activity had to be moved around. I am very happy to pick up domestic abuse. I think it would be good to have a statutory partner on board as well, but yeah, happy to take that forward.
That's brilliant, Stephen. Thank you for that.
Thank you very much.
Patrick, could you show your face, please? Patrick? Right, Patrick, you've made a brilliant offer, but I'd like you to do it on camera, please, because then you can't change your mind.
Yeah, sure, Councillor Hamilton. I think it's the points that I made around the mental health involvement with this piece of work, and just saying that we're quite happy to be involved with that work. I know that we some of my colleagues have been involved, but certainly if you're looking for some senior representation there, I'd be quite happy to be involved.
Thank you, Patrick.
Fantastic. Right, now, Luke. Oh, Dr. Aslam.
I just thought, well, we're in the kind of mood for giving. I was just reflecting on the diabetes work stream, actually, and if we match that into the obesity work, I would be really keen to be involved. And Richard just volunteered himself for another role, but I think as SRO of the West Birmingham Place, I think we would like to do some work around diabetes along the whole spectrum of obesity into pre-diabetes and diabetes. So I would be happy to contribute to that if you felt that was appropriate, Councillor.
Could I also say, relating to the diabetes one, you will be using some of those community champion experts that are out there that do a lot of work in this area. Please let us not leave them to one side, because they are key to some of the successes that we'll have in this area. That's fantastic. Luke, you've got the final word. And Dr. Munir, thank you. Bless you, thanks.
That's a wonderful return on 10 minutes work.
I've got one of the best boards in this council. They are brilliant. They always volunteer, never let me down. Right, now, what I wanted to do, we're just going to do the recommendation. So recommendation 3.1, which Luke had already gone through. Is that agreed? I just need one person to agree, and then if you could put it into the chat box. Is that agreed? Great stuff, great stuff. Now we're moving on to the bit about information items. Now, I wasn't very happy that the information item relating to the Sikh Community Health Report and the Bangladeshi Community Health Report, it was put in for information only. What I've done is I've asked Ricky, I don't know if he's here, but I'm hoping he is, Ricky Bandel, to just come and spend 5 minutes to go over the work, because if you get the opportunity to read these reports, they are excellent. So what I've asked the staff to do is to get Ricky to come on board, which he's here, and to just talk a little bit about what we did to pull those reports together, because I want the board to see some of the phenomenal work that is going on in public health at the moment. So Ricky, over to you.
Thanks, Councillor Hamilton. I was just trying to sort out the kids' food at the same time, so apologies I was a little bit late. Yeah, so the community health profiles. This was a bit of a discussion which was just pre-COVID. Justin and I had a conversation, but Justin was the kind of like the main instigator with all of this and the direction. And what we wanted to do was actually, for the first time, do a health profile on ethnicities, faiths, disabilities, sexual orientation in the city. And most of all, kind of look at the hard questions and some of the gaps in the data. Little did we know, through COVID a few months later, as it started, those kind of predictions on where gaps were and ethnicity data started to come to fruition. So this piece of work is a pilot. It's one of the only ones in the country that we're aware of. And what we looked at was to look at the existing kind of evidence base on communities and put it together in one central place. So the Sikh community was chosen first. My background is from that community. I'm from the city. I was born and raised in Handsworth. And I also had a bit of an idea of what the kind of data was already out there. And ultimately, this is the pilot and the test that what we're going to be doing. What I'm going to do is just share a couple of slides, which puts this into kind of perspective in the work that's been done. So just bear with me 1 second. So what we've got planned next week, Monday, is an actual external event to showcase this our findings to the predominantly to the Sikh community, but is open to everybody with organisations. We did a soft launch of this event on the 9th of September, which we had a really, really good feedback. One thing is what I want to show you. Let me just get it moving. One of the areas that we're looking to do is to expand on these profiles into a different ethnicity. So the Bangladeshi one is the one that's going to be following out of this, and we've got a soft launch date of the early October with that. So these are normally pieces of work that would have taken several months, but we're trying to condense that. And as we get better in our team of collating and bringing information together, we should hopefully see that kind of sped up. But the resource and the time that's taken is quite extensive. So what we looked at was pulling together the community health and wellbeing themes and relating the findings that we could do under these themes. So I will give kind of like a few headlines, but it also takes into accommodation the limitations of finding. I think that's really, really important, and the commitment that after 5 to 8 years, we will go back and update these profiles as much as we can, because we will see significant changes as now the pressure is on monitoring bodies to collate ethnicity data a lot better. We've put together kind of graphics in terms of where the Sikh Punjabi community resides within the city. Some of the key main health inequalities that we found out, but the question is what do we do with this information? So normally when some reports are put together, they've kind of showcased to a few people, and then they just get put on a shelf and gather dust. This needs to be palatable to the community to understand the intelligence that's been put together and almost kind of empowering that community on what the next steps are. So this is not recommendations. This is pulling together community intelligence, presenting it to the community, empowering the community to say, right, here it is, we can work with you, but we don't have the solutions as well at the same time. I'll just get down to the next part, which is probably the real gold of it, really. These are the infographics that we've put together. The actual document itself is an 80-page document. We've summarized it into four infographics. The next slide here will show you, you know, the themes of each of the areas that we've from our findings. We've then taken it and the next step further, which is to actually translate the infographics into Punjabi. We have then done the actual main document, the 80-page document, also into Punjabi, and we're also having a short 10-minute video narrated on the infographics in Punjabi language as well. This is going to be presented to an external audience on Monday. We've been keeping Councillor Hamilton up to date with our briefings and our findings and what we're doing. Yesterday at CLT was advised to send the leader a briefing, so we're putting that together. I'll be sent to Mary shortly after this meeting. And ultimately, what we're doing is trying to replicate this model for the Bangladeshi community as well, which is our next one. The one after that, we'll have 2 ready for Christmas, which will be for the lesbian community and for hearing impairment. We are planning an additional 10, hopefully to be done by March next year. So we will have real live community profiles for the first time that we're aware of. So it's a learning process. If you can share the engagement, I'll share the invitation out to everybody. So far, we've got just under 70 people signed up already for next Monday. We're hoping to try and get that over 100, which I'm sure we will be. It is getting quite a lot of attention nationally and internationally with some of the people who have been invited. Councillor Hamilton, is there anything that I'm missing on there?
I think you've done really well, considering you weren't supposed to be at this meeting and it was just a paper exercise. But I wanted you to share this with the board, because I wanted the board to see some of the phenomenal work that's going on. And also, if there is anything that you would like us to share with you within your areas that might help what you're doing, please come and ask us, because the work is being developed, it's there, and it's there for all of us to see and share and make use of that wonderful bit of data for the first time ever that we've got going around. So unless there are any questions, what I wanted to do was just ensure that you'd seen it all, that Ricky invited members of the Health and Wellbeing Board to the session on Monday. So if you've got an half an hour or an hour, I'm not sure how long the event will be, but you can go along and you can actually see what's going on. I read the Bangladeshi report yesterday, and I'm not going to lie, you can't put it down, because areas where you're thinking they would be struggling, it's not the areas where they're actually struggling. So it is a really good read, and it's one that I'd like to recommend each and every member of the board. If you find yourself with half an hour, please read it. It is interesting. So on that note, Ricky, I'd like to say thank you. Thank you for coming at short notice, but thank you for all you're doing, because it is a valuable piece of work.
Thank you very much. Yeah.
My pleasure. And what we'll be doing later on next year, you'll be formally coming to the Health and Wellbeing Board and presenting all of them in their entirety.
We're going to have a formal kind of launch where you would have where all the profiles that we've done so far. This is a commitment that's not just for this year. It will be a continuation of this kind of this work.
Fantastic. Thank you. And on that note, you can get back to your children's tea. Thank you, Ricky.
God bless Chase.
You. Right. Can I move on? There are other items for information, but can I just ask you, please, in your own time, please read those items. They're all really quite important items that we do need to keep a track of. Is there any other urgent business? I've got some urgent business. Stacey, can you put your camera on, please? Stacey Gunther is a young lady that has worked alongside myself and Justin for about the last 2 years, Stacey, and she has been a star. We would not have done half of what we've done with the Health and Wellbeing Board, getting the strategy together and what have you without her. Now, she doesn't know I'm doing this, but I know she's leaving us soon because she was nabbed. She is going across to the combined authority. She's been seconded by them. But you know what it's like. Paul will tell you, once you leave, it's very difficult to come back. You always want to go forward, because I've been one of those that have been seconded, and you never do go back. So I just wanted to formally put on record my thanks to Stacey for all her hard work. I will truly miss her. I have always told her that her husband should have been married to me. So I've said it publicly, but he won't have me. But saying that, she's leaving us. She has been a brilliant member of staff. I am going to miss her. She has been a wonderful support to me personally as a cabinet member. You don't have to ask this young lady to do things twice. It is just done. So I just want to thank you for all your hard work, all the support you've given us. I want you to enjoy your time at the combined authority. We will miss you. We will miss you so much, but thank you. And I just know whoever's doing this role behind you will have an hard act to follow. So thank you very much, Stacey, and you have a lovely evening. Okay.
Thank you very much, and to you and the board for all of your support.
My pleasure. Thank you, Stacey. Any other urgent business? Nope. The date and time of the next meeting will be the 30th of November at 30th of November 2021 at 3 o'clock in the main hall of the Midlands Institute, Margaret Street. And it will be a face-to-face meeting. So we will get the information out to you nice and early, but I'm looking forward to seeing everybody on the 30th of November. So enjoy the rest of your evening. Enjoy. We've managed to finish early, and just have a pleasant evening. And if you've got other meetings to go to, enjoy. So on that note, can I say good night and thank you all.